as great talks to us. Next we've got Anoop Jhurani, and he's going to talk to us about UKA, the only way is robotic. Thanks, Anoop.
Good afternoon, gentlemen. I'm experimenting talking without PowerPoints. So please walk with me as I share with you some practical pearls tips of advantages of using robotics in partial knees or unis. Now, unis is a great concept. It preserves the lateral and the patellofemoral part, preserves both the ligaments, is minimally invasive, gives great range of motion. There is decreased blood loss and there is decreased morbidity. But still at best, the results are 80% at 15 years. Why? Not because the concept is flawed, but because the execution has some serious challenges. Now, what are those challenges? Those challenges are on the tibial side, on the femoral side, and on the final sagittal and the coronal alignment. Let's address them one by one. In conventional uni, on the tibial side, you use 1 or 2 tibial pins to fix the jig. Then you use a horizontal saw which can undermine the tibial spine. Use a recip saw which can go on the posterior cortex. The slope is difficult to recreate, and a lot of x-rays we see anterior tibial slope because the vision is limited, unlike a TKA. Then to prepare the pegs, you hammer, and when you hammer for the preparation of the tibial pegs, the stress riser of the tibial pins and the peg holes can connect, and that leads to tibial failures. So a lot of failures on the tibial side are mechanical failures which can be prevented by robotics. How? So robotics completely eliminates those 2 tibial pins to hold the jig. It eliminates saw completely. The burr comes and burrs the tibia. The slope is recreated, that's very important. And you prevent hammering of those preparation holes. So the burr comes and makes those holes. So the tibial problems are completely eliminated by use of robotics, especially the mechanical failures and the anterior tibial slope, because with passive or active robotics, you can recreate the slope. So most of the problems on the tibial side are eliminated by robotics. Let's look at the femoral side. A lot of x-rays you must have seen where the femoral component is mal-rotated, especially in external rotation, causing impingement and early failure. So all those problems on the femoral side can also be reduced or probably be eliminated by the use of robotics. How? By manipulating, maneuvering, and managing the femur. So when you have hyperextension, you reduce the distal femur cut, so you distalize the femoral component. When you have fixed flexion deformity, you proximalize the femoral component. If you have tight flexion gap, you downsize and anteriorize the femoral component. If you have a tight flexion gap, you downsize and posteriorize the femoral component. So you can do all of that by manipulating the femoral component on the robotic screen, and that helps you prevent any femoral component rotational malalignment which can cause early wear. Coming to the final alignment, we see a lot of over-valgized overall alignment which leads to lateral compartment arthritis, progressive and early failure. That can be prevented because on the robotic screen you can see that you have kept the overall alignment in 3 to 5 degree varus. So over-valgization can be prevented by robotics. More important, on the sagittal plane, you can prevent hyperextension because the robotic screen is showing you. So you have to keep the overall sagittal alignment in 1 to 3 degrees of flexion, never hyperextended, never fixed flexion deformity. Please remember that unis are very sensitive to fixed flexion deformity, unlike TKA, where 3 to 5 degrees of FFD may correct by physiotherapy. Unis will never correct if you give them a FFD. So 1 to 3 degree final flexion alignment is paramount to success of uni, and that can be seen on the robotic screen. So more important than the coronal alignment, the sagittal alignment is more important, preventing hyperextension and preventing fixed flexion deformity. Coming to passive and active robotic systems, there are no studies comparing passive and active robotic systems as of now. but both seem to do the job pretty well. In passive system, we map and surface match the femur. The tibial cut is minimum, and most of the manipulation is done on the femur side. So it helps us preserve the alignment to 3 to 5 degrees of varus, minimize your cut on the tibial side, and do all the manipulation on the femoral side. On the active systems, we do the CT scan and get the overall alignment, see whether the case is fit for a uni, select the patient properly, use CT scans to surface match the femur and get your overall alignment right. So in summation, robotics has great advantages for uni, especially on the tibial side in eliminating the pins, eliminating the saw, and eliminating the peg holes preparation, which actually connects to the tibial pin stress rise and creates tibial stress fractures. And doing all the manipulation on the femur side in distalizing if hyperextension, proximalization in FFD, downsizing and anteriorization if the flexion gap is tight, and vice versa. And getting the overall sagittal alignment in 1 to 3 degrees of flexion, never hyperextension, never FFD. Thank you for your attention.